Hi, everybody. I am thrilled for this conversation coming up with Dr. Mark Trolice. Most of you know him as both an IVF specialist and also just an amazing patient advocate. We are going to be talking about stress and infertility today. And I think this is one of those topics that you can't really talk about enough because there are so many nuances regarding stress itself, both in how we respond to being in the infertility community and in sort of the domino impact of then the stress impacting outcomes. So we're going to cover all your questions today. He is joining in just a moment. I added him to the Instagram, and there he is, the fabulous, the fierce Dr. Trolice.
Hey guys, great to be with you all. Gloria, it's wonderful to be back with you all again. I think we did this not
We
too long
did.
ago.
It doesn't, I know, it seems like I just saw you the other day, but it was a month.
Just like yesterday.
Just like that. And since then, I've also received the COVID vaccine. So I feel like if we were in the same place, I'd be able to even give you a real hug.
We would give a real hug. We could feel immune, empowered, liberated. It's
Totally.
A beautiful, yeah. And while we're talking about that, everybody who's on, please get your vaccine. It is not going to cause infertility. There's no evidence of complications in pregnancy. It is our only ammunition to get rid of this awful, devastating, unprecedented pandemic. So please don't listen to any unsubstantiated conspiracy theories that there's going to be infertility or you're going to have problems. Gloria got the vaccine. I got the vaccine. Everybody I know got the vaccine. You just feel so much better as a result of that. And the vaccine can protect baby during pregnancy as well. So please.
Yes, I was so happy to see that the first babies being born have antibodies.
Yeah. So, you're getting the vaccine, but it's a beneficent gesture because you're not just doing it for you. You're doing it for your family. You're doing it for your friends and their family. You're doing it for everybody around you. We should feel responsible for our human race to do everything we can to rid ourselves of this awful burden. I mean, pregnancy is dangerous still. It's real. The complications are real if you get pregnant and are not immune. And unfortunately, you have higher rates of hospitalization, ICU, ventilator, even death rate. Gosh, so please do everything you can. If you are above the age or there's restrictions that you can't get it, please be extremely careful. Keep your social distancing. Wear a mask. We're not out of the woods yet. This is still here. Okay?
Exactly. Now, Dr. Trolice, Shalfa is asking us of the types of vaccines that have already come to market, being the mRNA vaccine and then the Johnson & Johnson viral vector vaccine. Is there a specific one that is recommended over another for those that are trying to conceive or those that are already pregnant?
Yeah, there's no distinguishing factors over the vaccine and you're trying to conceive. I think that the Pfizer and the Moderna have the higher percentage of immunity. But if your only choice, so first of all, any vaccine is better than none.
Yes.
Okay. And the original ones, the first two, Pfizer and Moderna, seem to have a higher percentage, I thought, than the J&J, Johnson & Johnson. So I don't think people are going to have the option, right? So just get the vaccine that's being distributed.
Right.
And then we adjust accordingly and see. I mean, if you need a booster down the road, whatever you need, but just get it.
Yeah. I love it. Okay. That was great.
Oh, that's a nice t-shirt. That's a t-shirt.
Just get it. That's a great t-shirt. I love that. And it kind of brings up this whole idea of stress. When we think about how stressful this last year has been on everyone, let alone those that are struggling to conceive, trying to conceive, evaluating all of their treatment options, with the recent literature and your recent write-up, what are you seeing about the impact or the correlation between stress and infertility?
Well, I wrote a commentary in the Journal of Assisted Reproductive and Genetics. It was an article that looked at, it was a survey of women who were undergoing infertility treatment and looking at their level of stress. Their level of stress was higher when they didn't feel the physician was engaged, okay, with them, if they didn't feel the physician was validating their concerns, if they didn't feel connected with the physician. Isn't that interesting, right?
Yeah, that
So
is interesting.
what I always tell my patients is that, here's the baseline stress, okay? Here's the infertility patient's stress, and the clinic that you visit should never be doing this.
Right.
We gotta be lowering your stress. Our place is your fortress of solitude. It is the only place in the world that should get what you're dealing with and should lower your stress and educate you and empower you and give you that feeling of hope. Now, in my practice, we use the acronym HOPE for have only positive energy. Okay. So please don't forget that. And this year has been indescribable. All of us have had to face unprecedented situations in our lives. But it doesn't mean that we cannot be grateful for what we do have. First of all, if you're on here right now, we can be grateful that we're on here right now and breathing, right?
Right.
We didn't get it, or if we did get it, unfortunately, we survived. So there's always room for gratitude, okay? Now, from my last time, I went through infertility for 10 years. I felt I was suffocating. And this is pre-COVID. I mean, this is years ago, right? So I get it. I have walked your walk. I'm not just talking the talk. But stress has not ever been shown to cause infertility definitively. Now, does infertility cause stress? Oh, you betcha. Okay, there's no debating that. But it bothers me when I see some of these articles about stress and infertility. Well, you have a 28-year-old couple or a 30-year-old couple, and they're married, and now after a year they want to have a baby. They don't begin their first month of ovulation timed intercourse wound up and overwhelmed. So the stress and infertility argument just doesn't make any sense to me. 6 months go by. Hey, what's going on here? A year? Yeah, that's not too good. People are really overwhelmed because when you go on Instagram, Facebook, or everything else, when you're trying to conceive, you're surrounded by pregnant women and you're surrounded by children. And people, you know what I'm waiting for? I feel bad saying this, but I'm waiting for the class action lawsuit of everybody who's put their people's children online, and the children get older and say, "Hey, I didn't want to be I didn't want to be paraded online. I want my privacy." Okay, and so I joke with my infertility patients. I say, I'm thinking these other people are having children left and right just to get likes on social media because all they do is put their children. So stress is a part of this disease.
Right.
And there was a study by Ali Domar, who's a nationally renowned psychologist up in Boston. Infertility, the level of stress and disruption in your life with infertility is equal to other major illnesses like cancer and heart disease. So anybody who tells you just relax, better duck.
Yes, exactly. Okay? They better duck. I agree with that.
Yeah.
There's a couple of really great questions coming in right now that I want to get to, Dr. Trolice. So Denise is having some physical stress right around her injection site. She feels like her technique is good, but is there something that you recommend when people are doing their self-injections to help kind of calm down that localized response?
Well, ice before can be helpful in numbing discomfort. Now, now there's two types of injections, of course. The subcuticular one that goes right into the skin, not too deep. And then if you're taking the progesterone oil, which is a literal pain in the butt, okay, it's in the backside, okay? That one's a little bit more uncomfortable. So the injection itself, you could use EMLA, EMLA cream, which can numb the area before you do the injection. And then maybe warm compress. Now, if it's starting to get, if it's starting to look red and you can get what's called a sterile abscess, which is a localized, very painful inflammation, stay away from that site. The progesterone injection is more at risk of getting that, although not common. So physical, stay away from that area. If it's
Okay.
subcuticular, like the gonadotropins, the
Hmm.
gonadolefts, and the follistems, you could do it in your tummy. You could
Sure.
do it in the front of your thigh. Okay,
So you have
not in the breast.
options, move it
Not in the
around.
breast. Yeah, not in the breast
Okay.
area. You know, the little fold under your skin here
Hmm.
is another place to give that. The progesterone injection, that's just your backside.
Yeah.
But if you're getting uncomfortable, stay away from that side. Now,
Right.
another thing, there was an article a few years ago to show that progesterone injection, I don't like giving just vaginal progesterone, okay?
Hmm.
Vaginal progesterone has been shown to be effective in fresh cycles, but in frozen cycles, vaginal alone just doesn't seem to be enough supplementation. So you can give vaginal, but every third day progesterone injection.
Got it.
Okay.
That's helpful. Yeah. I
Yeah.
mean, that comes up a lot. People asking about the difference and the efficacy between vaginal and the subcutaneous injections. So that's really
Yeah.
helpful. And can we find that EMLA cream over the counter? Is that something we have to get? We can get at CVS?
Yes. Over the counter, you
Okay,
can get
great.
Emla cream. Now, the stress is obviously physical, but it's also emotional and it's also financial. We don't have the
Right.
mandated insurance coverage that infertility patients deserve as a disease.
Agreed.
I'm fighting for you all.
You
I go to
are.
Washington, D.C. I'm involved in virtual advocacy events. I'm trying to get that in Florida as well. But so there are lots of stresses that are in play. Think about the stresses of people asking you, hey, did you have a child yet? Hey, did you get pregnant? Or
Right.
a phone call of the famous words, guess what? Okay. You just are victimized, unfortunately.
Yeah.
Strangers
Yeah.
at the cash register. Oh, how many
Exactly.
children do you have? You know, I completely get it. And I would also sympathize with you and empathize that in May is the worst day of the year. Okay.
It is.
So Mother's Day, try to think about how you want to handle that. If you want to stay home or with your partner and avoid events, the people who truly love you will understand. And if they don't understand, they really weren't your ally. So you
Hmm.
didn't lose anything. Okay. That's your day.
I
Make it your
appreciate
day.
that so much. I feel like we talked about this before too, and it kind of has a little bit to do with stress, and it's the word infertility. Many of us don't feel that we're infertile, even if we've had multiple miscarriages. And the even the definition of fertility is time based. It isn't as though you have PCOS or endometriosis or blocked fallopian tubes, or you just had an ectopic, where all of a sudden you finally get that referral into a quote unquote infertility specialist. So how do you even help us reconcile kind of that term? We have someone who had her second miscarriage and does not consider herself to be struggling with infertility, maybe because she has gotten pregnant twice, but she's also coping with a terrible loss. So how do you advocate that patients kind of make that bridge connection between, hey, you have an adverse fertility outcome, you have a right to go see someone who specializes in helping to achieve the fertility outcome that you so desire?
Yeah. Firstly, I would bypass the OBGYN as soon as possible. The sooner you go see a board certified reproductive endocrinology and infertility specialist, statistically, the faster you're going to get pregnant, the faster you're going to go back to your OB/GYN. Okay. Secondly, I don't use the I word. I use
Mm,
fertility. I have fertility
yes,
patients. I don't have infertility patients. I don't use that word. I hate that word. I
I
use
hate that
fertility
word too.
patients.
Yeah.
Yeah. And I actually don't even talk about it. I say, um, uh, recurrent miscarriage patients have recurrent pregnancy loss. Unexplained fertility problem is there. So I don't like to label the overall
Hmm.
disease. I think it's the elephant in the room. We all know why you're at our clinic. Okay. So
Right.
we try to just talk about what's the problem here. Okay. 40% is a male issue, 40% is a female issue, 20% is unexplained, 30% is a combination. Yeah, we get all that. But ultimately, I share with my patients, who cares what the problem is? I mean, the
Right.
baby's not going to hold it against you. Okay. If you get pregnant after fertility treatment, the baby's not going to say, what? Yeah, I mean, you had fertility problems. Why am I even here? You're not going to hear a baby say that, okay? So nobody's going to hold it against you. I saw a wonderful couple today. Man had severe male factor. He was devastated. I mean, you could feel the
Wow.
devastation. And I said, look, I'm going to tell you this. She didn't check a sperm count before she fell in love with you. All right, she's not marrying
Right.
you for your sperm, okay? It is what it is. In every sense of the word,
Yeah.
it is what it is, okay? After you have this baby, God willing, you're not even going to think about your sperm count. And the baby's not going to say, I can't believe you did IVF. It is what it is. I had male factor. My wife had some endometriosis. We had miscarriages, ectopic pregnancy. It didn't define me. Okay. I am on a soapbox of support for my patients and advocate. You can't let this define what you are.
Yeah.
Who cares the reason?
Right.
And even if you got, say, a sexually transmitted infection, you didn't say, I can't wait to get a sexually transmitted infection. You didn't say, I'm gonna have relations with somebody and I know they have an infection, but we're gonna have pregnancy. Sometimes it happens. Nobody deliberately sabotages their fertility. Okay.
Of course. Right.
So guilt, there's no room for guilt. Looking back only strains your neck. You can't do anything about what has been in the past. Forward. Forward is such a positive way of life. Okay? Looking forward. Tomorrow is the most exciting word in the English language because what it does, it's your own eraser. It's a clean slate. Whatever happened today
every single
is
day.
not tomorrow.
I love
But
that so much.
But the stress is if you carry that burden. Okay.
Yes.
And I'm going to
You're
share a
right.
couple other things. Yeah. And I'm going to share a couple other things. Nobody, I repeat, nobody makes you stressed. Nothing makes you stressed. Oh, my job's killing me. I'm stressed about my job. Oh, this coworker, I can't take her. She's stressing me out. I go home. I got these projects to do. They're stressing me out. No, we choose stress. Look in traffic one day. When you're in traffic, look around. When you're stopped, look around. You look to your left, this person's singing. You look to the right, that person's banging on the steering wheel. They're both in the same situation. Who's handling it better? And who is making themselves stressed? There is a checkbox, and you are checking stress or you're checking, this ain't going to get me. Now, I'm not saying this because I never get stressed. You talk to my wife, you could say, yeah, I get stressed sometimes. Yeah, I get stressed. Absolutely. But I'm also telling you, I know I'm making myself be like that. And the older I get, the more I'm trying to be mindful and emotional intelligence about that. I'm doing it to myself. And we're doing it to ourselves. Now, if you talk to your friends and you're stressed with fertility and you talk to your friends and say you're stressed out, oh, of course, I understand completely. All right, everybody gets it, but it doesn't have to beat you down.
Right.
When I think about cancer patients, and God bless them all. You are a survivor from the day you're diagnosed. Okay. Well, you're a fertility warrior from the day that you're diagnosed. And if you let that beat you down, you're hurting yourself. Stress does not cause infertility, but stress reduction has been shown to improve outcome. Okay. So be good to yourself. All right. There's no reason to blame. Whatever has happened, whose life is anything that they thought it was going to be? I see probably,
Not
I see
mine.
10, I talk in depth to about 8 to 10 new patients a day. I have never met anybody who said, oh, Dr. T, it's unbelievable. My life is perfect. It's other than the fertility, I completely planned when I was going to get married, my job, my life, the house that we're going to, nobody. So what are we going to do about it?
Wow.
We have to adjust to what we have and absolutely make the best of what we have. Play the hand that you're dealt. And there's a Chinese proverb about in a windstorm, Which tree gets knocked down? Well, the oak tree can get knocked down, but the bamboo tree that bends doesn't get knocked down. We have to
That's
adapt
right.
to what we
They
have.
are so
And
hardy,
thank
those
God we have
bamboo
the
trees.
fertility technology available today. Yep. We have fertility technology today. Now, the worst part of this, and I get this, the treatment is expensive. And that's the shame. We offer our own in-house financing. All right. No patient will be denied. And this isn't an advertisement, so please forgive me, but I'm just saying that I want to do everything and anything, and I call my colleagues to do the same thing. Okay. Whatever it takes to help a patient get through a cycle, we have to try to help them through that. And advocate to get insurance because it's the right thing.
Yes, it's the right thing to do. I couldn't agree with you more. And I'm so grateful for your advocacy work, the actual advocacy work where he's talking to legislators. He's going to Capitol Hill in the non-pandemic times. He's participating in the virtual advocacy day with Resolve. And we hope that you all will join us with that too. You can check it out at resolve.org. A couple of other questions that are coming in that are really important. One is that there are all these companies online who are selling things to quote unquote unblock fallopian tubes naturally. And this particular patient would love to hear, what your position is about that. Is there anything that can unblock tubes naturally?
Not that I'm aware. I know that there are some studies that have reported through abdominal massage to sort of break up adhesions. I don't know of good medical studies of before and after to support that. I would be wary of certainly I would not take any substance that you would get online. The natural methods, caveat emptor, okay? If there are true scientific studies to support in good medical journals that have undergone vigorous analysis that are publishing the data, okay, then I'm on board. I haven't seen it. I review articles in major medical journals. I'm a reviewer.
All the time.
I just don't see it. Okay, so please be careful. The only methods of reversal of a tubal blockage are procedural that we have right now. Okay, and speaking of such, a blocked swollen tube. So there's two parts of a tube. If my body is the uterus and my arms are the tubes, okay, there's the beginning of the tube and the end of the tube, the fingers, okay? The end of the tube, if that's blocked and swollen, that's called a hydrosalpinx. You want to address that before doing IVF. You either want to open the tube or remove the tube, because keeping that tube and doing IVF reduces success by 50%, because the fluid in that tube can decrease implantation
into the uterus,
anatomically, as well as reducing an implantation. Yeah. If the tube is blocked in the beginning, you could put a guide wire down. It's called fluoroscopic tubal cannulation, or through hysteroscopy. And those are methods that you could do that. 60% or more success in, or 80% probably opening at 60%, 40 to 60% pregnancy rate, things like that. But they can re-occlude about a third of the time. So evidence-based medicine, and feel good about the fertility clinic that you're with. If you don't trust, or if your gut is telling you something, believe it, because you may be getting upcharges. Okay, you may be getting doctors because there's a conflict of interest. I mean, unfortunately, if there is insurance not covering, this is a big revenue for doctors, and you got to be careful about that, unfortunately. So if you are worried about what this doctor is saying, get a second opinion immediately. Doesn't mean that you can't go back. The second opinion may say your doctor's spot on and you feel better. Well, the second opinion says leave tire tracks in that parking lot and get out of there. Okay, and that may give you reason to now. So just think about that. Think about what your doctor is telling you. Ask lots of questions. If your doctor gets annoyed over the questions that you're asking, that's a red flag.
Okay, great. I appreciate that statement so much. In case you guys need to punctuate it, if your doctor appears to be getting annoyed with the question you're asking, wrong doctor for you. It's time to get a new doctor. And that's from a doctor's mouth. That is straight from the specialist's mouth. So please listen to that great advice. We say that all the time. So we have a couple of users asking about miscarriage, and one gal's family kind of connects stress with her miscarriages, which sounds incredibly unhelpful. And someone else is asking, well, what does cause miscarriages? So could you kind of address both topics? What causes miscarriage, and then address, the misnomer that stress caused the miscarriage?
Yeah, no, the stress is not going to cause you losses, but I would share with you that there are randomized studies, good studies to show that close monitoring during the first trimester and supportive care, it's the TLC effect, seems to improve outcomes. So there is something there, but this is after several losses, okay? So I'm not poo-pooing stress and reproduction. I mean, in a woman, a woman's periods can stop with intense stress. I mean, concentration camps and prisons,
Sure.
your ovulation function is getting affected. I mean, stress, right? So what are the causes of stress? And by the way, we've just brought on a brilliant, recently trained physician, a fellowship in reproductive immunology, who is
Love
trained
that.
in pregnancy loss and implantation. So we are part of immunology and genetics. He's a PhD in genetics. So if you want a
Great.
telehealth consultation, you can see him, Dr. Giovanni Hubis. So we understand the immunology and the factors involved. So there are 5 explainable reasons that are sort of mainstream, unexplained 50 to 60% of the time. We consider pregnancy loss as clinical, identified pregnancy inside the uterus, 2 or more losses. 5 reasons for that. An individual random loss is chromosomal.
Sure.
More than two-thirds of the time, there is a chromosomal abnormality of the embryo. Nature said, hey, this is not going to be a good situation here. And nature takes care of itself, okay? More than two-thirds of the time. But 2 or more losses, you're still getting a higher rate of chromosomal abnormalities. Even with 2, 3, or 4 losses, you still have a higher percentage. But the more and more losses that you have, the less likely it's due to a chromosomal abnormality. So 5 explainable reasons. Yeah, 5 explainable reasons. One is unexplained 50 to 60% of the time. The other 4, there's genetic, there's a rearrangement of either mom or dad's chromosomes. They're fine, but when eggs and sperm get together, it throws it off. So you could either have a baby that's completely normal, a baby that has the same rearrangement as mom or dad, or completely unbalanced, chaotic chromosomes, and that's not going to work out. Rarely it will deliver. Second is anatomic. Anatomic, meaning that there is a malformation of the uterus, either due to something acquired, like polyps, which is an overgrowth of the lining, which is a fibroid, which is a tumor of the uterus, alterations of the uterine cavity. There's controversy right now about septum, which is a congenital. You were born with this malformation of the uterus, no health threat to you, don't worry about that. But there is concern over residual tissue when the uterus was forming to be a cause of loss, and whether surgery truly is going to reduce the risk of loss. We just got accepted a paper where we wrote on that, and that'll be coming out shortly in a journal called Fertility and Sterility, that it's debatable now. There's some controversy over whether it truly is reducing the risk of loss by doing that surgery. But that's been the traditional approach. Third, hormonal. We know thyroid dysfunction. We know elevation in prolactin levels, which is a pituitary hormone, can cause these losses. Elevations in prolactin can cause ovulation dysfunction. You may even see some breast discharge, milky discharge from the nipple. Those are issues. Diabetes. Patients who have very uncontrolled blood sugars can increase the risk of miscarriage. Yeah. Number 4 of the explainable reasons is thrombophilias. And these are the ones that you hear about, the anti-phospholipid antibody syndrome, which basically there's 3. The 3 mainstream ones. Dr. Hubis, my reproductive immunology colleague, does test for more. But we test basically, and I say we, in the reproductive endocrinology world, not the reproductive immunology world, we test
Right.
lupus anticoagulant, which is not meaning that you have lupus, anti-beta-2 glycoprotein, anti-cardiolipin antibody. If you have those, we repeat them 3 months later, and if it's still positive, then we give you a blood thinner injectable medication, typically something called Lovenox, which is a heparin-like medication.
Okay.
So those are the ones, and we do a thorough evaluation. We also do an endometrial biopsy because there is evidence that inflammation of the lining of the uterus called chronic endometritis, 25% or so of patients have a higher risk of loss. So we give antibiotics for that.
Wow. Okay.
So as you see, a quick question, how do we know if we have a chromosomal hormonal abnormality? These are blood tests. They're very easy to obtain.
Very, very easy to get, which is great. So
Yeah.
beautiful brown eyes
So,
went to her first acupuncture for fertility today too. Is
yeah,
that something that you?
no, acupuncture makes you feel better. Clearly, there's stress reduction in acupuncture. If you like doing that, that's great. No great definitive scientific medical evidence that's going to improve your live birth rate. Also, IVF, even with chromosome testing of the embryos, has not been shown to be any better than trying naturally to reduce the risk of miscarriage. So I do not support the extra testing or IVF for unexplained miscarriage.
Okay, really helpful. So, Mrs. Curlisu, she just moved to Orlando and she can't wait to be your patient. She already loves your personality and your energy.
Oh,
So,
well,
yeah.
I truly hope that you don't have to see me, but if you do, I'm honored to take care of you.
Dr. Perlow is also recommending the Sanera patch to numb the skin prior to injections. So he's in our audience today. Hi, Dr. Perlow.
Oh, Dr. Parlow's here. Oh my goodness.
Yeah.
Yeah. Mark, wonderful to see you. Dr. Perlow is an outstanding physician in Atlanta who has contributed to our field for many years, and I'm honored that he did. And he's making a very good point. In polycystic ovary syndrome patients, the most common hormone problem in women, affecting 5 to 10%, some studies up to 20%. It's a hormonal imbalance. It does seem to be a higher risk of infertility. Dr. Perlow is mentioning that controlling PCOS could be a higher rate of live birth rate. Difficult to know exactly how to control, unfortunately, PCOS, but they have a much higher rate of prediabetes, so we give them metformin.
Yes.
So he's a retired physician. I didn't know you retired, Dr. Perlow. My goodness. Well, our loss is your family's gain. Yeah, metformin we give for patients with prediabetes. I don't know if there's really good medical evidence to support that's going to improve outcome, but in terms of live birth, metformin, there is debate over its use and how it's going to improve live birth rate.
Right.
But the American Society for Reproductive Medicine does advocate metformin for patients with prediabetes, certainly above a BMI, a body mass index above 30. We give metformin for those kind of patients as well. So it's a difficult, I'm laughing at Dr. Perlow's comments. But it's a difficult application of knowing when to use metformin.
Right.
I don't think it's necessary for women who don't have prediabetes and who are thin, but in women who have prediabetes or have an elevation in body mass index, yes, metformin is utilized.
Okay, there's another great question here. If you only have a low-level mosaic embryo, and I know my business partner Santiago Monet just came out with a study recently about mosaicism and kind of clinical guidelines, right? Would your clinic transfer a low-level mosaic?
Yes, excellent question. I will be moderating a major live webinar sponsored by the American Society for Reproductive Medicine next month. It is going to be for all the clinicians. It's for colleagues about PGT, debating universal versus discretionary use. And we have just amazing, eminent physicians, Dr. Richard Paulson in California and Dr. Eric Foreman in New York. So I can't wait for that. Mosaic. Fairly controversial. The American Society for Reproductive Medicine did come out with a consensus statement recently. We never go to mosaic as first line, okay? The recommendation is to use all of the chromosomally normal embryos first. If you
First.
don't have any more chromosomally normal embryos, the recommendation is, unfortunately, if you could do another IVF cycle, we would recommend doing that. Going to mosaic, if there are no way you could do another IVF cycle, if there are absolutely no euploid embryos, then seeing a genetic counselor with reproductive experience, reproductive genetics experience, to counsel you over the risks. Now, fortunately, low level mosaic has not been shown to have untoward outcomes of baby. And yes, we would, as a program, transfer low level mosaic. I'm leery about high level. I think also there's a debate over whether we're even going to be doing levels. It's either going to be
Right.
mosaic or not. So this is a field in flux. And I would also share with you that we actually have reports in the world of transferring a chromosomally abnormal embryo, not mosaic. And those babies actually have shown to do well. Mosaic embryos have a lower implantation rate, higher miscarriage, lower pregnancy rate, but it's not unprecedented.
Right. That's what makes it so controversial and difficult to talk about, is when you have success stories. And I think for the patients, that if that's their only option, they hang on to hope, right? Because there still is some level of success with
Well,
certain
yes, but
mosaic
yeah,
embryos.
but we're not talking about high levels of success. And yes, we
No,
have that,
we're
and we
not.
have,
Yeah.
and we do have desperation patients,
Hmm.
clearly, but that should never be exploited, and that should only always be thoroughly counseled with
Right.
appropriate information so that the patient is fully informed, so that
Very
and
good
she
point.
understands the risks and benefits of their decision.
And I'd like everybody to understand that there's different levels of informed consent. And Dr. Trolice is a great example of fully informed consent. I think you can tell by this live, he doesn't leave anything out. He will stop and make sure that everyone understands exactly the information that he's delivering. And not every physician is like that. Not every doctor, not every clinic is like that. And in fact, Dr. Trolice, we've seen some clinics who really it might be left to the patient to figure out that there is such a high first IVF cycle failure rate. And, I know that this does not exist in your clinic. So how did you go about even training your staff and even training yourself that it's okay to tell the truth
Yep.
about the level of failure expected in a first cycle, where you still leave
It's
someone with
it,
hope?
it's let me just correct you right there. It's not okay to tell the truth. It's mandatory. Okay.
Thank you.
If the information that we provide turns a patient away, then that was the right thing to do, not to turn the patient away.
Mm,
But I tell
but to
all of
tell
my
the
patients,
truth.
I tell all my patients, I want you to know the outcome, because
Hmm.
I never want to sit here afterward and you being devastated about never knowing how poor the odds were.
Right.
So
Right.
every IVF patient, we go online. And guys, if you're considering IVF, take this website down. I am on the committee and the Electronic Communications Committee for the Society of Assisted Reproductive Technology. It's called SART, SART.org, okay, ORG. In the top menus, you're going to see patient outcomes, I believe, or success rates or something to
Hmm.
that degree. You just do the drop down, do patient success rates, put your information in. It is a wonderful tool. It is for all, it combined all the programs in the country that to be able to give an estimate, a good estimate for your chance of live
Yes.
birth from 1, 2, and 3 egg retrievals. Okay, so what do we consider a cycle? A cycle is 1 egg retrieval and
Mm.
all of the fresh and frozen embryos that came from that 1 egg retrieval. So before my patients do an IVF
Love
cycle,
it.
they know we look at it as a cycle of using all the embryos. okay? And it's cumulative though. After the first cycle, you'll see if you ever have to do another egg retrieval, it's actually a little bit higher. And then for the third cycle, a little bit higher. Now, I'm not advocating, nor do I look forward to doing second cycle on you and a third cycle on you. I hope, first of all, I wish you didn't have to do IVF. And then first, I hope that if you do IVF, we're successful first time. But it just gives you a reasonable estimation of the outcome. I saw a patient today, maybe 43, 44. Tubes were tied. I believe she was told that she should do IVF. I said, let's look at this. The success with IVF is based on the age of the woman traditionally, and ovarian aging is twofold: quality and quantity. Quality is based on your birthday. Can't change that. As you get older, it's only going to go worse. Quantity is based on AMH, your anti-Müllerian hormone. Incidentally, you shouldn't be getting FSH levels. If a clinic is doing an FSH level on you, unfortunately, they probably have the hormonal assay right there, and they're running that, unfortunately, okay? FSH has been outdated for more than 10 years. AMH is a direct measure or indirectly estimation of the numbers of eggs that you have, okay? So the lower the AMH, the lower the numbers of eggs that we would get. It goes down as you get older, and it does influence the success rate with IVF. What it doesn't influence is your natural ability to conceive. Dr. Ann Steiner in North Carolina looked at women aged 30 to 44. This was in the Journal of the American Medical Association, okay, just a few years ago, and looked at their natural pregnancy rate. Very low AMH levels, normal AMH levels for the woman's age. Ages 30 to 44. Age per age, what was the difference in their pregnancy rates? Nothing. They got the same pregnancy rate, natural pregnancy rate, whether their AMH level was low or not. So I saw a patient today, 34, from Miami. Her OB-GYN, she was having some irregular periods, gets an AMH level, low AMH. Oh my God, you better go see a fertility doctor because you got to freeze your eggs right now. Or do IVF right now and get pregnant. She came to me as soon as we said hello on my telehealth. Hi, how are you? So where you from? Blah, blah, blah. I said, are you ready? Don't worry.
Wow.
And she's almost ready to start crying.
Oh.
I said, there's no AMH level in a woman who's not infertile that's going to influence your family planning. Your cycles are monthly. You don't have hot flashes. Your mother didn't go into earlier menopause. There's no premature ovarian failure in your family. You have no significant risk factors for premature ovarian failure. Live your life the way that you want. Get pregnant when you want. Now, you're 34. If you say, hey, Dr. T, I'm not going to get pregnant for 10 years. Well, okay, then maybe you might want to freeze your eggs a little bit earlier. But don't use some simple blood test to change your life's plan. Really be very extensively counseled. And she was very, very much appreciative of the consultation that we had. So, you got to put it all together. So quantity and quality of your eggs, as you get older, it's going to go down, but it doesn't mean that you cannot conceive naturally. So the woman with the tubal ligation, she was 44. We went online with the SART calculator that I just gave you the address. Her chance of IVF with one IVF cycle using all the embryos eventually, less than 5%.
Okay, let's actually repeat that, what you took us through, because a couple folks are kind of wanting to repeat what that cumulative increase looks like. So if they go to the SART website, and it's also because you are so animated when you talk, they go to the SART website and they see 1 egg retrieval, 2 egg retrievals, 3 egg retrievals, their success rates will continue to increase with each subsequent retrieval, correct?
Yes, after the cumulative, an IVF cycle is 1 egg retrieval, and then using all the embryos that came from that one egg retrieval
Gotcha.
eventually.
Okay.
Eventually.
So you could have 3, 4 FETs or so forth.
Yeah, FETs, I'm sure you all know the lingo, but that's frozen embryo transfers. If an embryo is frozen and you thaw it, we transfer the embryo back inside. Okay. So
Okay.
that 44-year-old woman who had a tubal ligation, I recommended a tubal reversal because studies have shown that her success rate with a tubal reversal at this age is probably near 40 to 50%. And what was the IVF success rate? Less than 5%.
Right. Okay. Okay. Got it. And then, so Dr. Perlow is clarifying too, and someone else just asked this. So does the pregnancy chance increase on the second and third and fourth frozen embryo transfer? Okay.
Yeah, no,
Got it.
within that one IVF cycle,
It
every,
counts. Yes, I get it.
it's actually confusing for all of us too about
Yeah.
why
Right.
cumulative takes effect. But what's happening is that you're eliminating the denominator. So the less
Okay.
the less of the numbers that you have, so 1 out of 10 is a lot lower than 5 out of 10,
Mm-hmm.
right? So the more people that get pregnant going through the cycle, the others have gotten pregnant, right?
Mm-hmm.
So as
Okay.
you go through it, there's less people that are trying, but those that try, if the denominator is lower, it's a higher cumulative pregnancy rate.
Got it. Okay. I think I got it anyway. All right. Here's a question not related to the statistics side, but Amy's asking, is there another cause of a high prolactin if you've already ruled out tumor, pregnancy, or breastfeeding?
Yes. Oh my gosh. Prolactin is one of those full page reasons. Okay. So,
Great.
prolactin goes up with pregnancy because of estradiol. Estradiol, which is in the family of estrogen, is your main estrogen. Estradiol goes up and it gets the breast ready for milk. Okay. So prolactin physiologically has to go up in pregnancy. When you're not pregnant, what's the reason? Well, sit down, get ready, because it is physiologic, it's pharmacologic, and it's pathologic. All the P's, okay? So physiologic,
Wow.
it could be after ovulation. Estradiol levels are higher as well as progesterone, but it's the estradiol level. So sometimes we'll get a progesterone level in the second half of the cycle to see if you've ovulated. And she may have gotten a prolactin for whatever reason during that second half of the cycle, and a prolactin's elevated. So what I tell them is I say, look, I wouldn't get worried. Your progesterone level is high. That means you've ovulated, and your prolactin level is probably elevated because of that. So we just repeat it. And when do we repeat the prolactin? Well, on her period, early in the morning, and fasting, because meals can affect it.
Oh.
Sleep can affect it. Intercourse can affect it. Nipple stimulation can affect it.
Wow.
Time of menstrual cycle, all that fun stuff. Okay. So what kind of pharmacologic agents? Well, typically reserpine, phenothiazines, the tricyclic antidepressants. There are things like that. Dopamine blockers. Okay, dopamine blockers. Dopamine is a powerful hormone. Prolactin is the only. So you got your pituitary gland, which sits behind the eyes, and there's a forward part of the gland, which is called the anterior, and a back part of the gland, which is the back seat. Okay, that's the posterior. All right, the anterior pituitary has all the stuff that we talk about. FSH is produced from there. LH, TSH to stimulate your thyroid. Prolactin. Okay, all those other guys are stimulated from the top brain center called the hypothalamus. Tells the pituitary, hey, let's get going. I need some hormone stimulation. Prolactin is the only one that's under constant blockage.
Wow.
Okay, yeah, and dopamine is blocking it. All right. So when anything reduces dopamine, any medications that reduce dopamine increase prolactin.
Wow.
Right? Anti-seizure medications. So we give a dopamine agonist, which means that it increases dopamine and that lowers your prolactin. Okay.
Got it. Okay.
Pathologic. Yeah. Now, it's not a tumor. When your prolactin level is elevated, we get a picture of the brain called an MRI, and we're not looking for a tumor.
Mhm.
We're looking for, I call it a thing. I never say you have a tumor. We call it a thing, okay? Because if I call you up and say, hey, your MRI is a little bit of a tumor, you hear the phone drop, okay? So it's a collection of
Right, of
cells.
course.
It's called an adenoma. An adenoma is just an overgrowth of cells, okay?
Okay.
And that is unfortunately just causing some elevations in prolactin or blocking dopamine, okay? So there's different collections of cells. So we call it adenoma. And if it's a little baby adenoma, we call it a microadenoma. If it's a big adenoma, it's called a macroadenoma, okay? So that's one. You could have something empty cella syndrome, which is an increase, which was pushing the anterior pituitary to one side and also can be blocking dopamine. Um,
Okay.
God forbid, tumor. Those things can do that as well. So pathologic causes as well. When we have a patient who has breast discharge, milky discharge, we get a prolactin level, we can do a breast exam with our OB/GYN, and then we look at the milky discharge under the microscope. And it should look like what we call fat droplets, which are completely benign. And so just to give that reassurance right away. So prolactin
Right.
is something in the reproductive
Complicated.
endocrinologist world. Yeah,
Uh-huh.
but this is what we're trained to handle.
Right. So I think the biggest takeaway from that is that if you're concerned about your prolactin, repeat it on your next period, right?
Yeah. Repeat it in the morning,
Yeah,
fasting, on
I
your
love
period.
that. And the morning fasting and on your period. All right, we only have time for one more question. CP, can people get pregnant if they have CP? I don't know what CP stands for.
Cerebral palsy, is it? Would that be? Could you clarify? There's a
Yeah,
question
let's
about
clarify.
endometrial
Andrea,
receptivity
clarify.
assay. Andrew, please. So there's a question about endometrial receptivity assay
Mm-hmm.
for recurrent implantation patients. It's only valuable if you're doing recurrent frozen embryo transfers, okay?
Got it.
And if that's the case, you have to realize there are some caveats of that test. It biopsies only one section. The lining of the uterus, called the endometrium,
Mm-hmm.
does not grow in sync. Some areas are more advanced than others, okay? So I don't feel that that test is the end all be all. Do I offer it to patients? After 2 unsuccessful frozen embryo transfer patients, I tell them that that test is available, but there's some caveats. Yes, it's cerebral palsy. Cerebral palsy is a physical handicap. I don't know of any impact on reproduction. Okay, so I would just ask your main clinician, as
Mm-hmm.
well as a high risk obstetrician, to ensure that there should be no impairment over your ability to carry the pregnancy. If there's any other physical concerns, and then obviously we proceed. But the most important factors for fertility, right? Are you ovulating? Are your fallopian tubes open? And do you have a good amount of sperm? Right? Those are the main things. Let me just do a quick little thing. The prolactin issue are the 3 F's: fasting in the early follicular phase, which is on your period or right after that, and free of stress. Fasting, free of stress, follicular phase. Okay.
Okay. Excellent. That was fantastic. Dr. Trolice, as always, thank you so incredibly much for lending us your time and your expertise and your generosity. Thank you also for being an amazing patient advocate. This is why we want to keep having you come back. The way that you describe things with such passion and enthusiasm and filled with hope is really just unmatched in our field. So we're so incredibly grateful for you. And thanks
I'm
everybody for
honored.
watching. We
I'm
love
absolutely
having
honored
you.
to be with you all. Thank you so much. My book is the Fertility Doctor's Guide to Overcoming Infertility. You can get it on Amazon. It's anywhere along your journey. It's a guide for you. It's part of my story as well, of my personal challenge of fertility. I pray for your success. I want you to know that you are not defined by your ability to procreate. You're defined by what you do in your life. What your gift is, what your talent is, your gift from God, but what you do with that talent is your gift back to God. So my prayers are with you all.
Thank you. All right, Dr. Charles, we'll see you again. Thanks, everybody. We'll catch you next time.